Hi, I'm Gabriel, and I am a psychiatrist at Tan Tock Seng Hospital. So today I'm going to be talking about the mental state examination. So these opinions are mine, and they don't express the views or opinions of my employer. But let's just get into the content. So what we will be going through today includes, firstly, why we might want to use the mental state exam or the MSE. Then we will discuss what the components of the MSE are. And finally, we'll go through parts of the MSE that students commonly struggle with. Now, when we ask why we do the MSE, we can think of it primarily as a communication tool to convey what we think is going on. So, for example, a term like pressured speech would commonly be associated with a manic state. By including relevant positives and negatives like the presence or absence of pressured speech in our presentation, we indicate to our audience our working diagnosis. Now, the second purpose of the MSE is as a trending tool. Unlike the rest of medicine, there are very few laboratory tests that we can use to tell whether or not someone is responding to treatment. And this is especially important when it isn't the same clinician seeing the patient over and over again. While inflammatory markers can decrease with antibiotic therapy, the only way that we may know whether or not a patient is responding to psychiatric treatment might be because of how we are presenting the MSE over time. So what this implies is that the MSE is a cross-sectional assessment. So you only report how the patient was at the time that you assess them. Finally, there are times when we may make inferences of the patient's internal experience based off of how they present. We won't be covering this during this session. However, I did want to say that in line with the first point of naming diagnoses, we also want to consider the underlying etiology when we are doing our presentation. For example, this graphic is meant to represent a man with Parkinson's disease, where the mask-like facies can mimic a blunted affect. Now, we want to make a distinction between the two because if we were to say that this patient's affect was blunted, what we are implying is that the underlying disease is that of a schizophrenia or some kind of psychotic disorder. However, if we know that the patient has Parkinson's, then instead we should be using mask-like facies to communicate what we think, what we know of the underlying etiology. Okay, so here we have the components of the MSE. Some of the other components might include things like insight as well as cognition, which tend to be a little bit more relevant if the patient doesn't adhere with recommended treatment or if they have some kind of a dementing illness respectively. Otherwise, these are the more common components, and in this particular slide, I've separated them into objective and subjective sections. Now, objective components are observations that are made by the clinician, while on the other hand, subjective components are things that you rely on patients to tell you about. So what this implies is that even if a patient has catatonic mutism, you as a clinician would still be able to make a comment on their appearance, behavior, thought process or lack thereof, and their affect. Now, I just wanted to discuss very briefly about thought content and risk assessment because I'm going to go into greater detail for the other components. Thought content refers to ideas and beliefs and pathological findings that typically fit into this bucket in the MSE would include things like obsessions and delusions. Sometimes if someone is anxious about something, we might also want to report that they may have a preoccupation about something in this particular section. Risk assessment, as the name suggests, refers to whether or not the patient expresses thoughts of harm to themselves or to others. Now, we typically start the MSE by reporting about a patient's appearance and behavior. I like to think about appearance as only what you can describe from a photograph, and this is distinct from behavior, which would involve a person's activity. Now, we might say someone appears anxious in regular day-to-day speech, but I like to get you to think about why you might think someone is anxious, and you'll realize that unless they're sweating, it's seldom because of their appearance. More often than not, it's because of their posture or how they carry themselves. In other words, it's usually their behavior which clues us into the fact that they might be anxious, or that their facial expression, which would then be referring to their affect. So going through these three pictures, starting on the left, if we just comment on his appearance, we might say that this is a middle-aged man wearing a bikini. And it's a little bit artificial because this is a static picture, it's not an animated GIF. However, for the purposes of this exercise, we might assume that he was dancing, and if he was highly energetic, we might present his behavior as psychomotor agitation. Now remember what I said about thinking about the diagnosis that you want to convey. If I wanted to convey the sense that this person was manic, I might say that their appearance-wise, he is a middle-aged man in a bikini. Behavior-wise, he displays psychomotor agitation, and he may also display overfamiliarity. Now, again, just moving a little bit further and just thinking about how people with mania typically present, we might present speech to be pressured, and there might be flight of ideas. Affect might be labile, and mood might be presented as euphoric. In terms of thought content, we might present someone with mania as having grandiose delusions, and he may or may not deny perceptual disturbances, and typically there may not be any expression of thoughts of harm to self or others. So do you see how you might not want to present every single finding if it isn't going to be adding to the impression that you're trying to convey? Now, moving to the lady in the center, we may say that the vibe that she's giving off is that of a person who's depressed. But if we ask ourselves why again, we might say that it's because of her body language. So appearance-wise, we don't see anything that's really strongly suggestive of depression. We can just say that she's kempt and that she's a lady. But behavior-wise, we may say that her eyes are downcast and she's got poor eye contact. And if she's not forthcoming when we ask her questions, we might say that she's guarded. Now, finally, on the picture on the right, if let's say we are thinking about how this might be a common presentation for somebody that we might see in public who may be talking to themselves, this might be someone who we might suspect to have some kind of a psychotic disorder, right? And if we were to just jump straight into how we might present their MSE, we might say that this is an unkempt man, that they present as agitated, and that they display hallucinatory behavior as they are talking to themselves. We may present their affect to be blunted and their mood to be euthymic, or we may say that their mood is irritable. We may say that they have paranoid delusions when it comes to the thought content, and we may also say things about their thought processes as having some kind of derailment or loosening of associations. Finally, we may say that they are experiencing auditory hallucinations, but that they deny any thoughts of harm to themselves or others. So moving on a little bit to some of the other areas that we want to discuss. One of the other difficulties that many students have is differentiating between affect and mood. So if I'm not going to repeat a lot of the stuff that would already be covered in your textbooks, but generally how I think about the differences between affect and the mood is if you look at the descriptors, affect typically refers to generally how the expression of somebody's emotional state is moving across their face, whereas mood is more of a qualitative something that we report to be a quality. So if we look at some of these descriptors, affect, for example, can be reported as reactive and appropriate. So this would be somebody who doesn't have any kind of a mental illness, for example. Or we can report their affect to be restricted or blunted or flat. Now, we would typically use the term restricted for somebody who is anxious or depressed. For example, what that we mean by restricted is that there isn't a lot of change in the way that they emote across their face. All right. Blunting is typically used when we have somebody with schizophrenia or some kind of a psychotic disorder, and what that means is that even if they may be expressing some kind of an emotion, we typically do not see any expression of that across their face. Finally, flatness is something that's similar to restriction, but it's reserved for use when we are talking about someone with depression. Now, the opposite of restricted affect would be a labile affect. So this would mean that the affect is changing very rapidly and quite wildly. All right. And comparatively, we can also describe affect to be inappropriate, or we can describe it as shallow. Right. So an inappropriate affect might refer to somebody who says that they are feeling very sad or very depressed, but as they are doing so, they are smiling. Okay. So that would be an example of an inappropriate affect. Comparatively, a shallow affect might be one whereby a person is actually displaying changes in their emotional expression across their face. However, it's not something that you are getting the sense of a very deep emotional experience. Okay, so it's a little bit difficult to convey over a lecture like this. However, it's something that once you've seen, you're never going to forget. So again, the affect is something that's a little bit more objective. We include it in the objective section of the MSE, and this is something that the clinician assesses and is something that we would actually regard to be a little bit more valid. Okay. Comparatively, mood is more subjective, and this is something that you have to rely on the patient to tell you about. Okay, so some of the terms that we would use to describe mood might be euthymic, so somebody who neither feels particularly overly happy or overly sad. We can describe mood to be dysthymic or depressed, which I think is pretty self-explanatory. Mood can also be anxious, and also if let's say someone was manic, we might describe mood to be euphoric, elated, or hyperthymic. So you can see how the affect really deals a lot more with kind of how the expression is moving across their face, but it doesn't really tell us so much about the quality of the emotion at that point in time. That would fall more into the realm of the mood. Okay. Now moving on, speech proper and thought process. In Singapore, we typically think about when we say that we want to present the speech, usually what we mean is an amalgamation of both the speech proper as well as the thought process. Okay, but if we are just focusing on speech proper, what that refers to is the qualitative aspects of speech sound. So this would be things like how fast someone is talking, whether or not they are speaking in a very loud volume or they are speaking very softly, whether or not there is a very odd rhythm to the way that they are speaking. Okay. One of the other things that comes under speech would be the quality of a pressured speech. Now, this is something that's closely associated with a manic state, and usually how we understand it is when someone's speech is pressured, that it's very difficult for anyone else to interrupt the person with pressured speech. Okay, now the reason why I bring this up is because a lot of people tend to confuse pressured speech with flight of ideas, which I'll get into in a little bit. All right. Now, the way that I think would be most helpful when we are thinking about the differences between the two is that speech doesn't really tell you anything about what the person that you are describing is thinking. Okay, all we can conclude by a presentation about somebody's speech proper is really whether or not they are talking fast or slow, and this would clue us in or provide further supportive evidence for some of the other things. So for example, if let's say somebody was dysarthric or dysphonic, then that may indicate that this person may also have suffered some kind of a neurological injury. So typically we want to look out for whether or not in the presentation of the person's behavior there were other features such as whether or not there was a unilateral weakness, for example. Moving on to thought process. Now, this is really a description of how ideas connect. So typically, we would think about somebody with no cognitive impairment. When we think about the way that they communicate, it will make sense that their ideas are very, they flow in a very predictable kind of a stream. Right? If let's say somebody were to ask them a question, they will be able to respond accordingly. And if let's say there was some kind of a misunderstanding on the receiver's end, then they could also pick up on that and tailor their delivery so as to mitigate any kind of misunderstanding. So that is actually what we mean when we say that somebody is coherent in their speech. Okay, so coherence is actually a very high bar that someone would have to be to meet in order to conclude that they were coherent. Goal directed, on the other hand, it's also in the same kind of domain, but you don't need to kind of fulfill as much in order to conclude that someone is goal directed. For example, if let's say someone was really trying to just convey certain messages. For example, if somebody said that wanted to get someone else to do something for them, right? They may say something like, okay, could you cook lunch for me, right? And that might be enough to get the job done. Now that would be an example of goal-directed speech, but we don't necessarily know whether or not, there are other more complex processes going on. For example, whether or not they are doing so because they are hungry, or because they are trying to exert some kind of a flex over the person who they are requesting that favor from. Now, finally, we have relevant speech. Now, this is a lot of people confuse coherence and relevance, but they are actually quite different. So, when we think about relevance, we could also think about this other idea of approximate answer. So, if I were to ask you how many legs a dog has, most people would say 4, right? However, if let's say the dog had gotten into an accident, we might say 3, and that would still be an appropriate response. However, what if someone were to say that a dog had 8 legs or 7 legs, right? The fact of the matter is that by giving a number as a response, it's still a relevant answer in certain to a certain degree, right? Because you're asking how many, right? And the appropriate answer would be to give a number, all right? So sometimes, if let's say somebody has poverty of speech, or someone has an underlying dementia, then we might actually say that the answers that they are giving are all very appropriate, but we may not be able to declare whether or not they are goal-directed or coherent. So what I mean by this is that if we ask somebody with dementia, for example, whether or not they would like to eat, right? A yes is a very appropriate answer, but beyond the fact that it is relevant, we may not be able to declare anything else about their thought processes. Okay. Now, moving down the line, we start to look at stuff that's still that's still non-pathological, but might start to be a little bit weird. And the further down the line we go, we start to see how the ideas actually stop being connected in a way that would typically be associated with a cognitively intact person. So circumstantiality and over-inclusivity generally tend to refer to people who are very long-winded. For example, some people might think that I'm going into excessive detail as I describe this slide. Okay, I might be over-inclusive. However, if let's say we go down to the idea of tangentiality, all right, this is where we actually start to think about the inability to actually stay on a certain topic. All right, so tangentiality might be something that you might see in somebody who may actually have other features of mania. All right, so they start talking about something, but then they go off on a tangent. All right, or it might be something that you see in someone with delirium because they are not able to pay attention to what it is that they are talking. Right, their working memory is so short, they may go off on all of these tangents. In a similar vein, flight of ideas is something that also is very closely associated with a manic state. All right, but the idea here is that the connections between those ideas is very tenuous. Okay, just as soon as I touch on a certain idea, right, I immediately start to go on to the next idea, which is also somewhat associated. So I might say that you might ask me what's my favorite color, and I might say black, and the next thing that I might talk about is how ninjas in Japan typically are associated with black clothing, and ninjas also carry a lot of swords and other sharp implements, right? And sharps are something that we want to get rid of in the hospital. So that's an example of a flight of ideas, because you can see how there is a connection between each of the examples of what it was I was saying, but because of the rate of speech or the rate of thought that someone with mania has, it's very much sped up. That's why it's very difficult for them to stay on what it is that they want to convey to their audience, right? It just goes off in all of these different directions. The next 3 items, loosening of association, derailment, and word salad, these are all varying degrees of what we would consider to be psychotic speech, or speech that's associated with psychosis. All right, and what this would involve is a breakdown in the connection of ideas at the level of the sentence, at the level of the phrase, and at the level of the word itself. So for example, if let's say we're talking about someone who has loosening of association, what we might see is that the first sentence does not have any connection to the second sentence. All right, whereas somebody with derailment might actually their speech might actually be the starting of the sentence and the ending of the sentence don't seem to be connected. And finally, somebody who is displaying word salad, what we might see is that from the first word to the second word to the third word, there's really no connection between the first and the second, or the second and the third. All right, so basically what we are seeing is that the breakdown in the ideas, they're starting to break down more and more frequently, and the ideas are being broken into smaller and smaller chunks. Again, with this idea of psychosis is the ideas of neologism and metonym. So neologism is essentially making up of a new word to describe something, and this is really associated with psychosis because people with psychosis are considered to have some kind of a break from reality, right? And typically when we talk about language, when we talk about speech, there are certain syntactic rules that we need to follow, right, in order for everybody to be on the same page. Now, if let's say someone has a very bad psychotic disorder, what might happen is that even though they, in their mind, right, they understand something, they want to convey this idea to someone else, but the thing is that they are not able to appreciate the fact that they need to follow these syntactic rules, right? So there's a loss of reality testing, and that is why they have come up with all of these new words to express certain things, right? Not realizing that these are words that only they can understand, no one else can. All right, so that's how we've hypothesized neologisms to have come about. Metonym, on the other hand, is when you use existing words in an idiosyncratic way to mean something. Okay, so almost like neologism, but these are actually words that exist. Okay, and finally, moving on to delusions and hallucinations. Now, some students actually confuse the two, and really these are the most commonly thought of features when we think about someone with psychosis, right? But the main difference between the two is that delusions, like obsessions, really are things that would be better categorized under thought content, and these are things that are thoughts, beliefs, so on and so forth, whereas hallucinations, on the other hand, these have to do with perceptions. Okay, so the official definition of a hallucination is a perception in the absence of a percept. Okay, so you're seeing something even though there is nothing there to see. You're hearing something even though a sound has not been made. All right, so by virtue of that definition, in order for us to say that something is a hallucination, right, it would have to be something that was picked up in one of the 5 sensory modalities. Okay, if let's say somebody said, one of the patients that we were interviewing said that, okay, I think that a certain person, is trying to hurt me, then we would typically follow up that question with, well, how do you know? And they may say, the reason why I know is because, I am hearing this music right now, and as you are there with the person, you don't hear any music. Right, so what that means is that there are 2 processes going on, right? The first process is actually the fact that they are hearing music even though there is none, okay, and that would actually constitute an auditory hallucination. All right, the second process is somewhat different. Okay, the second process is how we have misattributed this conclusion to hearing that music. All right, and the conclusion that this patient has come to is that someone is hurting them. Okay, so without actually saying whether or not this is a delusion, I hope you can kind of see how it's a little bit different in that the thought part, the interpretation, that is a thought, okay, and that is nothing to do with the hallucination. The hallucination proper only deals with the experience that can be picked up in one of the 5 sensory modalities. Okay, now simply put, you guys would have known from your textbooks that a delusion is a fixed false belief out of keeping with social cultural norms. Okay, and the reason for this is that there are going to be times where a certain belief may be no way to validate whether or not this is true. Okay, and a lot of times, if let's say we want to be a little bit a little bit provocative, we can think about religion, for example. When do we go from it being a legit religion to being a fringe religion to being a cult, right? And even if it was a cult, typically we don't regard them as delusions, or we may say that we talk about it in the context of it could possibly be a shared delusion. All right, So the thing is that delusions are always ideas and beliefs, and they do not always have to be linked to a sensory experience. So when we're thinking about whether what the patient is displaying in front of us is a delusion or if it's a hallucination, that is going to be the main thing that we want to be looking at. Okay, so that is my very brief presentation on the mental state exam. I hope that that was helpful in just going very briefly into some of the difficulties that students have faced before in the past. But moving forward, there will actually be a face-to-face session. So if you do have any questions, please feel free to ask the lecturer at that point in time. All right, thank you.